Good afternoon, everyone. Good afternoon, everyone. Myself, Dr. Deepthi Warikoo, Department of Physiotherapy, Dolphin PG Institute of Biomedical and Natural Sciences. I first of all welcome you all on this webinar on evidence-based management for low back pain. I welcome our guest for today, the speaker, Dr. Amar Suhail, lecturer, Maldives National University. Dr. Suhail was formerly working with Lovely Professional University. He has 18 publications to his account. Being a teacher and mentor makes Dr. Suhail equally educationist as he is a physiotherapist. Dr. Suhail is also founder of Curious Physios. Today we have this opportunity to welcome Dr. Suhail to deliver this lecture on low back pain, which is indeed a rising issue in current world. On behalf of the management of Dolphin PG Institute of Biomedical and Natural Sciences, our chairman, Mr. Arvind Gupta, principal, Dr. Shailja Pant, director, Mr. V.K. Nagpal, and additional director, Mr. Sunil Kaul, I welcome you to this webinar, sir. Now, not taking much of your time, I would start off the seminar and hand over the screen to Dr. Suhail. Dr. Suhail, could you please continue? Welcome, sir.
Good afternoon, ma'am. Thank you so much. अब देखिएगा पीपीटी आ गई. Okay, good afternoon, everyone. My name is Ammar Suhail, and I'm working currently as a lecturer in Maldives National University. And today we'll be speaking on um, a condition which I guess every one of us experienced and has an experience of in terms of clinics and in terms of personal experience also. So we have seen patients as well as we have experienced back pain in our context also. So we'll be talking very generally about why this is important and how do are we going to deal with this. Okay, so if anybody has any questions, definitely we can you can ask at the end. So we'll continue without any interruptions. Right. So before starting and before approaching the patient, the first and the foremost thing that should be clear in our mind is that back pain is a symptom, right? Now, the starting point of the assessment should be that it is a symptom. It's not a disease, it's not a diagnosis in itself. It's a problem which arises from underlying cause, underlying disease, underlying pathology. So whenever we see a patient, first and the foremost thing, the first thing that should come into our mind is that it is a symptom. I want to assess and see why the patient is having this back pain and what can be the cause of this back pain. Right now, I may be able to find out the cause, or I may not be able to find out the cause. Depends on my assessment. So this is the basic starting. Uh, thing that every physio should remember, right? That back pain is the starting is a symptom, right? It's not in itself a condition. So once we have understood that, the first and the foremost component comes to our mind is history, right? So, okay, I understood that it is a symptom. What next? So when we go next, we go to the patient and we ask him, why are you here? What are the problems you are having? And what are the things that you are experiencing? Okay. So we listen to the patient. We listen to him attentively. We do not interrupt, and we listen to gather as much as information as possible about the back pain, right, or the condition in general. Now this is very important because half of the questions that we have in our mind will be answered by the history of the patient. So if we listen very attentively, you should be able to reach a diagnosis most of the times, right? So listening is very, very important. I cannot overemphasize the need of it. The history is very important. As we go along the presentation, we will see why history is such an important concept here, right? So once we have listened to the patient, right, I'll come back to these slides after this. So history will do what, right? So we need to understand that history will provide us with various hypotheses. What are hypotheses? Hypotheses are differential diagnosis. So when we listen to any patient, right, he tells us that he has a pain in the knee. So we ask his age, we ask his occupation, we ask his problems, we ask what are the problems he's facing, all those things. Depending upon that, right, we try to identify what he might be having. So when we listen to his problems, his age, his activities of daily living, we try to make a speculation. We try to estimate that okay, this may be the condition or this may be the condition. So depending upon that, we try to assess and confirm at the end that okay, this is not osteoarthritis, this is a fracture, or this is not a fracture, this is an osteoarthritis. Similarly, in back pain, listening onto the history, we try to understand okay, what kind of back pain it is. Is it really musculoskeletal in nature, or is it because of any cancer, or there is a fracture? What is the possibility? So hypothesis basically is the clinical condition the patient may be having. So you may have five hypotheses, you may have six hypotheses, you may have seven, depending upon your experience, depending um, upon your experience and expertise. So history will come from where? History will come from the patient. We have to listen to him, and listening to him will make us understand. Okay, this is the situation. Now our assessment is just to confirm, exclude, include these hypotheses. So I will assess range and further things and many other things, psychosocial factors, and I'll come to an idea that okay, this hypothesis look good, this diagnosis looks good, and the patient may be having this, or this does not look good, the patient may not be having. Okay, so this is the second thing. So first thing is history, and then from the history we deduce a lot of um, questions, right? We deduce a lot of theories. So our hypothesis, as I said before, will guide our actions, our assessment. It will tell us basically uh, where should we go? Should we get an X-ray or not? Should we get an MRI or not? Or is it just a simple back pain? Or is just a spasm? What is the situation at the moment? So the situation is through the history, right? So this is in general, right? What we do. So we examine, right? Examination involves everything, including history and everything. And the green box I've created is for after listening to your patient and examining and assessing. Sometimes we may refer the patient. We may refer him out to another consultation, right? So maybe an orthopedic surgeon, maybe a cardiac surgeon, depending upon what we found out from the history and the examination. Sometimes we may not refer. Okay, we may start treating, we may diagnose, we may provide a prognosis to the patient, and we may go for an intervention and then see how the patient is progressing and how the patient is improving, right? So when to refer and why to refer is the question. Okay, and we'll be discussing that also in detail. So my whole presentation is based on this paper, and this is published in European Spine Journal. This says that your patient should be divided into three different categories, okay? Or your back pain patient should be triaged into three different categories. Now, those three different categories will dictate how you're going to manage your patient, right? So the topic is management of low back pain. So what management we give to a client depends upon the assessment, right? How, in which category the patient lies, basically. Okay, so let us look at that. So this is the diagram that they have proposed in the paper. In many other papers also, similar diagram has been used, and I use this in clinical practice as well as in teaching both. So here, what they are saying is, you take a patient, right, who comes to you with the presenting complaint, chief complaint. You document the chief complaint, and the second step you do is you ask history, right? You ask focus history and physical examination. So you ask patient, okay, questions like how is your pain, what is the duration, how did it happen, right? What are the symptoms, what provokes it, what are the aggravating factors, what are the relieving factors. All those questions are asked in the history itself. Okay, and then from this history we decide whether my patient is having back pain which is coming from somatic source. Now what do I mean by somatic sources? From musculoskeletal structures. So is it coming from ligament because of an injury to the ligament, or is it coming from because of a muscle weakness? What is the source of back pain? There, now, as I said, it is a symptom. There can be non-spinal causes. Non-spinal causes means red flags, conditions which are giving back pain to the patient, but they are non-musculoskeletal in origin. They are not treated by physios, like cancer, right? Like vascular syndromes, like aneurysms, prolapse uterus. These are conditions which basically are not treated by us in the first place. We basically will refer this patient for further consultation, right? And after the primary consultation, right, maybe anything, uh, the patient will be, may come back to you or may not come back to you. So I hope up till here everyone is clear. So what is the first thing? When the patient comes to us, first thing to be clear in our mind is that it's a symptom, right? So after that, I start looking for the why the symptom is there, right? Why the back pain is there. So how do I look for answers? I look for answers from the patient. I ask questions, okay, specific questions, and I ask him, okay, what all things are going wrong? How are you? What are the symptoms and all those things. So listening to all these things, I conclude that you have an MSK related back pain or you have a non-MSK related back pain, right? So this is the triage we are creating, right? One section and the other section. So the one section is we are referring, and the other section is basically we are giving it to ourselves, right? We are treating it at the base. So these are some of the non-musculoskeletal causes which are documented in various literature. They can result in back pain, right? Prostatitis, pelvic inflammatory PID, duodenal ulcer, acute pancreatitis, nephrolithiasis. These all structures, these all problems can cause back pain, right? So you should be very thorough and very clear about, okay, these are not present. Okay, if these are present, then our treatment, our management won't result in any success. It may even result in harm to the patient. So these are known as red flags. Also, these are known as non-musculoskeletal causes also, and we need to rule them out. We need to exclude them. We need to understand that these are not present. Okay, now how do we make that sure, and how do we know that uh, these are not present is the question, right? So we need to screen for red flags. Now you need to ask yourself question, and if you know, you can type in the comment section also. How do we screen for red flags, right? We all talk about red flags every time we study ortho neuro, right? We have to screen for red flags, right? We want to know what are red flags, but basically, how do we know that the person is having a red flag or not is the question. So, right. Any? Okay. So there are various theories and in literature various things that is said as how do we screen for red flags, right? But the most evidence based concept is that most of the red flags can be deduced from the history itself, right? So when we ask questions to the patients, we should ask relevant questions, and those relevant questions should lead us to the red flag, right? The examination, there are various examination strategies and assessment strategies that have been documented, but they all lack reliability, validity, and credibility at the moment. So only thing we have at present is the history of the individual, right? So we can only deduce by asking those relevant questions. Okay, that it can be like weight loss and had a fall, injury, fracture. All those things can be only asked from the history. So how relevant history you take is very important. Okay, now I want to make a point here again is that don't be afraid about red flags. Red flags may or may not be always red. Means some of the red flags which have been proven as red flags are being discarded. So if you're interested in reading more about red flags, you can go to this paper. This paper talks about that some of the red flags which we have been saying they are red flags are not proven. So only those which I have shown you, right? And apart from that, quad coina and fractures are the only uh, ones where you can uh, think of that they are red flags. Okay, so this is the third thing, right? So first thing we did in history, second thing we did is understanding the problem of the patient and dividing it into MSK versus non-MSK, and then from there on we went on to assess the red flags. So now we have a clear idea in our brain that okay, this patient is MSK related, I need to treat it. So now the next step is to divide it into three different categories. Okay, uh, some back pain will have a specific uh, disease, underlying disease. Okay, some will not have a specific disease. Okay, and some may be caused because of the neural structures. So the problems which arise from the neurovascular structures, we call them as radicular syndromes. Right here, the problem is with the nerve or with the spinal cord, as per se, right? So, like you might have seen also, you might have heard also sciatica, right? So, sciatica is a radicular pain, right? It's a radicular syndrome. Lumbar canal stenosis, we have heard of. So, it's a radicular syndrome, right? It results in narrowing of the canal, compression of the cord. As a result, we see symptoms. Uh, these are radicular problems and they can be diagnosed based on history and examination, right? The other section here, which you can see on your screen, is specific spinal pathology. Now, they are very rare. First of all, most of the back pain is rarely due to specific spinal pathologies, but they do exist. So we need to know about them. So there can be many, like vertebral fractures, cancer, right? Uh, Infection of the spine, tuberculosis, quad equina, ankylosing spondylitis, okay, any other forms of spondyloarthropathy. These are specific causes. That means we have definite tests to identify these diagnoses, right? We have definite tests to identify these diagnoses, like vertebral fracture, you have X-ray, malignancy, you have an MRI and a biopsy, spinal infection, you have infection tests, right? Blood tests, axial spondyloarthropathy, you have X-ray and MRI. Quad equina syndrome, again, you have an MRI and X-ray. Uh, right? So these have a definite, they have been proven that we can diagnose them, right? Okay, so third one is the non-specific one where we currently do not have any tests. If there is no specific, if there is no radicular syndromes, right? We do not have any specific tests to say that it is facetogenic or it is discogenic, right? There are some tests, but again, as we are talking of evidence, it's still lacking. So yes, there may be, we are not sure that there can be an SI sacroiliac joint pain, but we are not sure of. We do not have tests at the moment. So I hope everyone understood this thing, right? So triaging the patient basically means dividing into three different categories: specific, uh, radicular, and non-specific. Now your management will depend upon what is the patient having. If he's having a specific spinal pathology, you will treat it accordingly, right? And if you have radicular syndrome, you will treat it differently. And if you have a non-specific back pain, you will definitely treat it differently, right? That makes sense. So this is the steps we are going to follow. Okay, I hope that's okay. So let's talk about few of these conditions. Quada equina is one of those which you should know. And if you are practicing in a clinic, you must be able to catch it, so as the patient does not suffer from emergency consequences. Now, quad equina syndrome is not very common in the population, but I have seen one or two patients, I would say, and you can very easily identify it using the history of the patient. So what basically happens in the quad equina is there is a tuft of uh, uh, conus medullaris, right? If this conus medullaris gets compressed or get an ischemia because of various reasons, the patient may develop something known as quad equina syndrome. So how do we identify this? The patient will have radicular pain, so it's going into the legs and it's burning, shooting, severe pain. Plus, the pain is in dermatome pattern and there is loss of sensation and there is weakness of the myotome. So you assess uh, the patient, you see that sensation is gone and there's a lot of weakness present, right? Reflexes, if you check, will be diminished in this patient, and rectal examination is no longer considered essential. Without even that, you can say that the patient is having quad equina and you can send the patient for an MRI. Okay, like anal sphincter tone and sensation is not checked because of various medical legal uh, problems in some countries, but in some countries it is still allowed and it is done. So this is your patient, right? 35 years old, having bilateral radicular pain. You assess and you find that sensation is lost, myotomes are weak, reflexes are altered. You may suspect a quad equina. Apart from that, there will be a loss of sensations to light touch, pinprick in the saddle region and the preanal region. Apart from this, the patient may also complain of bladder and bowel issues, which will confirm to you that this my client is having an emergency quad equina and he needs to get an MRI done or a referral done, right? So we refer this out. We do not treat it. Maybe once the conus medullaris is relieved from the pressures and the tensions, then whatever was causing the compression is released, we may see the patients. In milder form of quad equina, we may see the patient directly. Second is spinal fractures. India is a country where we see a lot of spinal fractures. In West, it is very rare. But if you're practicing in India, you must be aware about it. Fractures, how do we diagnose? We all know history of the patient. So dig in deep to the history, ask, have you ever had any fall? What are your vitamin D levels? What are your calcium levels? Are you an osteoporotic female? These questions you should ask, and depending upon that, you may suspect, okay, there may be a fracture present. So how do we do that? We palpate the spinous processes, right? And on palpation of the spinous processes, the spinous processes are tender. So tenderness is a clinical sign that there can be an underlying fracture present. Or you can do a percussion on the affected level. So on the spinous process, you can percuss, or you can just percuss with your finger. This may again create the pain and discomfort, which may again suspect that the pain is from the fracture. This is easy, right? So you just send for an X-ray, get an X-ray done, and rule out the fracture. Malignancy, in my personal experience, I have seen one case who had space occupying lesion, right, in the thoracic spine, because of which he was having back pain. Uh, the five most common cancers which were benign and became metastasized and comes to the spine are breast, prostate, lung, kidney, and thyroid. So you must remember these five, sorry. And whenever you see a history, right, she had a breast cancer and now she's having back pain, be alert. Similarly, kidney, lungs, and colon. There is a very good slide which I found yesterday, and I've been is eight signs of detecting cancer. So you can ask these questions to your patients. Is there any decrease in weight? Do you had any unusual bleeding or discharge? Is there any change in bladder habits? If these questions are positive, definitely the patient may or may not may have a cancer, right? So a referral is also important in this case. If you have now, okay, so there are some other specific causes which are not red flags where we do not need to refer the patient. So these were the causes where you need to refer your patient to another healthcare provider, right? But here you may treat the patient on your own, like ankylosing spondylitis. It is a specific cause, but the treatment is physiotherapy. Dish, this is diffuse idiopathic skeletal hyperostosis. This is again manageable by physio. Uh, I have seen three cases in primary care and assessed them. One here in Maldives and three there in India. So it's very common. Smoking is one of the risk factors. So if you suspect there is stiffness, smoking, change in posture, go for dish. Get an X-ray done again, and you will be able to have a diagnosis. Disc ruptures, so disc gets ruptured completely. Herniations, we can treat them. We know now that conservative care is better than surgery. So again, it's not a red flag anymore. It's just a specific cause. So now we know, sorry, now we know something about specific spinal pathology, right? So I'll repeat. So low back pain is a symptom. The first thing, from history, we understood that the patient do not have any non-spinal cause. We moved ahead. We try to look for red flags. Out of those red flags, some were specific causes which we can treat. Some were non-specific causes. Some were specific causes, but we cannot treat them. They were red flags. So we again classified them into separate categories and we understood the patient. Now comes the second category, which is radicular syndrome. And in radicular syndromes, we need to look for these three things: radicular pain and radiculopathy, and canal stenosis. Now, radicular pain, understand it as a nerve being irritated and is causing pain, right? And the pain is usually shocking, electric, very severe along the course of the nerve, right? Which is different from radiculopathy. Radiculopathy, your patient may present with objective signs of neurological deficit, like change in reflexes, dermatomal pattern of sensory loss, or myotomal weakness. Okay, so objective neurological signs will be present. Right, objective means you can measure them, and that is because of a nerve root compression. Radicular pain, we do not have these signs. Neurological signs are not there. It's just a nerve being irritated. Okay, it's just nerve being irritable because of lack of blood supply, compression, inflammation, anything. So the nerve is just shooting abnormal ectopic discharge, which is conveyed to the brain as pain. So pain, the brain perceives that it is radicular pain. Okay, so I hope that's fine. Now these two are very common, and we see in back pain a lot. Right, sciatica. Sciatica is what? It is a radicular pain. It's not a radiculopathy. Radiculopathy is where you will see a foot drop. Okay, next stage. So there is compression, there is inflammation, and the nerve has given way. So there is a foot drop. There's a complete loss of sensation. There's atrophy of the muscle. So it's the radiculopathy phase. Now, somatic referred pain is what? Somatic referred pain is sometimes with back pain, you also have referred pain. Referred pain, classical example is you have a problem in the heart, but you get pain in the jaw or in the left arm, right? It's a referred pain. It's not radiating. Heart is somewhere else, and the hand and the jaw is somewhere else, and other anatomical regions. So similarly, back you have pain in the lumbar spine, or you have problem in the lumbar spine, and the pain is being felt in the calf, in the leg, all those areas, right? So this is known as somatic referred pain, right? Now there are various theories of why there is somatic referred pain happens. We don't go into that. We just try to differentiate between the somatic and radicular. Now remember, somatic will be less severe and back pain will be more severe. Leg pain will be less severe. Radicular is opposite. Back pain is less severe and the leg pain is more severe. So this is the basic difference between the two. There are various other differences like quality, right? One is very vague and dull. The patient cannot tell you the exact origin. Radicular is he knows, right? It's going in the back of the leg, it's going in the right of the leg, and there will be temperature differences between the two, right? So this is the story of this. This is defined by Bogda. So this is the second category of our discussion, right? So I hope these categories are now clear to you. So specific spinal pathologies, some of them are red flags, some of them are not. Radicular syndromes, some of them, okay, so radicular pain, all those things we understood. Now, how do we manage these is a question, right? So these specific spinal pathologies, we treat them in multidisciplinary setup. We refer them or we take help with rheumats, and along with that, we give them exercise, right? This is how we manage the patients. Now, syndromes, right? Specifically sciatica, leg pain, referred pain, stenosis, all these are treated according to guidelines, right? According to evidence-based practice guidelines, which are being published. So one of them being published is by NICE guidelines, which talks about these things. So these are the only evidence-based approaches available. Apart from this, whatever you see in the internet or what you are seeing being practiced is not evidence-based. It's just is according to me. It's not proven. It may work, may not work. Uh, doesn't have reason. It may have reason. But the goal of our lecture is to understand what is evidence based. So the first thing and the best thing that works is to is to calm down the patient, explain the patient that there is a problem, right? And what is the problem? Majority of your patients want an answer to their problem. They have been told stories, different stories. Their sacrum is up and down, and their God knows what. They want a simple answer. So if you can educate them that there's a nerve pathology and how the nerve is causing pain, half of their problem is solved. Trust me, I've seen a lot of patients, enough back pain patients to say that this is the best treatment out there, right? So there was a client once who had been told has ankylosing spondylitis. We assessed them, right? I didn't, we as a team assessed and came to find out that it's just a simple back spasm, right? Once the patient was told that he doesn't have ankylosing, half of the pain was gone, right? Because he has read everything on the history on the internet and was very afraid about that. So, according to the patient, right, educate efficiently, adequately, appropriately, right? Second best thing that works is exercise. Nothing works better than this. This is my personal experience as well as evidence says the same thing. Uh, any form of exercise is like a magic to back pain, right? The more you move, the better it gets. So choose what fits your patient, right? There's no one fit size that fits all, right? So it can be an aerobic, can be strengthening, can be cycling, can be just swimming. So we had a patient here in our university yesterday who had scoliosis, and the doctor has referred him for physiotherapy and swimming, right? So swimming is another form of just an exercise, right? So exercise works best, right, for sciatica and radicular syndrome. You can use manual therapy, right? But it should not be used alone. It should be used along with an exercise program. So you should just not use manual therapy. If you just use manual therapy, what will happen is your patients will keep on coming back. They won't improve for a long term. So in order to get 100% results, you need to club it with exercise. Then we do not prescribe NSAIDs and opioids, but they are an option. They are a recommendation. If the person is in too much pain, definitely they can take medications. Newer addition to the recommendations is neural mobilization. If you're skilled in that, use it. But remember, the nerve is irritated. If you overuse it, it will cause you pain, right? It will cause the patient pain. So use with caution, right? The now this is all about the management, right? Now in lumbar canal stenosis, radiculopathy, and radicular pain, the biggest question is, should we operate, right? What is the right time for operating? Okay, does it make sense? So usually patients ask, uh, the pain is not going away. Can we get a surgery done, right? The answer to that is very difficult, in my opinion, because there is no reliable evidence at the moment. So timing for surgery is not well established. This paper talks about when the surgery should be done, but again is unconclusive. We do not know whether this is going to surgery is going to work or not, and when to give this patient surgery. Right. Then we have non-specific low back pain, right? The last category. And the last category basically is when we have done everything and we are still not sure about what is the cause of the pain, right? That time we give it a category known as non-specific low back pain. Now, how to treat this one? Uh, Everyone is treating it according to their whims and fancies, right? They are doing whatever they want, and there is n number of articles and n number of opinions on how to treat non-specific mechanical low back pain. But in my personal experience and according to the evidence, again, the reassurance and education works the best. So educate and tell them that this is going to go away. There's a very good natural history of back pain is must. Second thing is advice to uh, stay active. So means exercise, right? So don't take excessive rest. Maybe one or 2 day is good, but not a complete bed rest. And then exercise, right? Exercise according to the physio. Whatever you prescribe, the patient has to do that. Manual therapy is can be used in combination with exercise and other modalities, and some people are using cognitive therapy, cognitive functional therapies, and all those sort of things also. So this is in a nutshell what we do with our patients, right? So right, and then once the pain turns into chronic, the things become further complicated, because then the brain comes in and the central sensitization and various other theories are coming up. So this is just yesterday, I guess, it published. What should we give to our patients with chronic low back pain, right? And it specifically talks about uh, what is the best one. So the best one is they have suggested is a combination of manual therapy and exercise is the best form of uh, treatment, right? So this is for chronic low back pain, right? So last but not the least is whenever you're treating the patient, right, try to focus on the biopsychosocial model, right? In that you will be able to understand that you are dealing with not just the biological component of the individual but also the psychological and the social aspect of the pain. So that, right, because recent researches have shown that psychosocial factors also play a significant role in your patients with back pain, right? So very commonly we get asked, we are asked that what are the different scales that can be used for patients with psychosocial factors. So these are some of the scales, right? If you are doing research, if you are a PG student, you must know about them. It can be used in common back pain patients, and they will give you an idea, right, that whether the patient is having any psychosocial factors or not, right? Uh, there have been a criticism that there is no evidence. So I have chosen a paper to highlight that psychosocial factors are relevant, and this is Indian study. So I have genuinely on I specifically selected this study just for the sake that this is an Indian data, right? We usually criticize that it is not an Indian data, we cannot apply. So this is an Indian data done in Delhi, where they found that psychosocial factors were more prevalent in causing back pain uh, than the biomechanical factors. So think globally when you're treating your patient, right? Don't just stick to bio. I know Indian physios are more specifically focused towards the biological concept, and we always are like biomechanics is altered. I'm not saying it's not important, but it is just one part of the picture, right? So if anybody has any questions, I can take that. This is all from my side. I guess everybody understood what are the different steps we need to follow, and the triage is very important, right? So if you need this paper, I can share it with Ashish sir. He can share it with you. This triage will help you in identifying your patients, right? Thank you. If anybody has any questions, right, we can take them.
Any questions, students? You can ask it. Good evening, sir. Myself, Dr. Diksha Bhatt. Any questions? You can write it in the chat box. Any question? Please write it in the chat box. Okay, one question is there, sir.
Yes, when there is reduced spinal canal diameter, that's a good question, right? So when there is a reduced spinal canal diameter, we call it as lumbar canal stenosis. If it's in the lumbar spine, if it's in the cervical spine, we call it as cervical canal stenosis. Now it depends on where is the stenosis. First thing, is it the central canal? So we all know, right, that there is uh, two vertebrae stacked on each other, and there is an intervertebral foramen, right? Sorry, the central canal is there. So if the compression is there, right, or if the compression is in between the transverse process, the intervertebral foramen. So this is the first thing that we need to identify: where is the compression, and how much is the compression? How much is the reduction in space? If the reduction is and what is causing the reduction, right? So if the reduction is caused by bony structures like uh, ligamentum flavum or osteophytes or any disc material, right? Then physio may bring temporary relief, but long-term relief is the surgical opinion, right? Uh, okay, so that's the first thing, right? If the canal size is highly narrowed, the surgical opinion is better. If the canal size is less narrowed, right, we can go for our forms of treatment, right, our different forms of exercises and all those things. So first, when you approach this kind of patient, try to identify what is the stenosis caused by. If it is a bony structure or a ligament or an osteophyte, it's tough to deal with. But if it is a disc, uh, then of course physio is going to work best. How to decide exercises in these cases? To decide exercises in these cases, we usually decide on the basis. You can use different approaches, right? One of them is McKenzie. So check for the extension and the flexion bias of the patient. Usually, stenosis patient will be flexion biased. So we decide on doing a lot of different kinds of extension exercises and strengthening exercises, stabilization exercises. Uh, right? That's the way we decide exercises. Apart from that, gait training is very must in these patients because canal stenosis causes neural claudication. So you need to train the patient to walk, and walking efficiency has to be improved. So two things you need to take care. First, identify where is the stenosis, what is the cause of the stenosis. Depending upon your prognosis will be there, and exercise selection will be based on McKenzie approach, flexion biased versus extension bias, right? Uh, it doesn't mean that extension is um, completely contraindicated. We can still do extensions, but within the limits of the patient, right? Is it possible? Is not possible with physiotherapy. Physiotherapy is just providing an environment for the spine, and the spine will regenerate on its own, right? Homeostasis is normal capacity of the body to heal. We are just giving an environment. In no way we can increase or decrease the size of the diameter. We Some people say that we do traction and the space is increased, which is of course not that true. As I said before, if it's an osteo degenerative cause, it's not possible to increase the diameter. But yes, if it is a osteogenic cause like this, um, inflammation, physiotherapy can increase the diameter. Means we can provide an environment and exercise where the body will heal adequately and the size of the diameter will improve. I hope that answers the question. Okay, there is one more question. How do we approach a patient with S1 radiculopathy post spinal anesthesia after cesarean section? That is such a specific question. Uh, uh, See, S1 basically here, what you're trying to say is because of anesthesia, the S1 nerve root is affected, and anesthesia usually produces ischemia to the nerve roots, right? The dorsal root ganglion. With time, right, that is going to decrease. That's a very important thing to remember. So when you approach this patient, the first thing is to educate her that this is going to get better with time as the anesthesia effect fades away. This radiculopathy signs and symptoms will reduce. Otherwise, apart from that, we treat radiculopathy like we treat it. So myotome weakness, we improve the weakness, right? Sensory loss, we treat the sensory loss, right? Sensory re-education. Other than that, the movements whichever are restricted, we improve on those movements, right? Like through manual mobilizations and exercises. Cesarean is done, the muscles are going to be weak. We know that, right? The abdominals are weak, so we need to strengthen that, right? So overall, this is how you approach, but educate first that there is an ischemia in the patient terms, right? You can explain, right, that there's a structure which because of anesthesia got inflamed. With my therapy, it's going to get better, right? And I'm going to do some things like exercise and manual therapy, which will improve your pain as well as discomfort and your problems. I hope that also answers the question. Right? How to diagnose LB? I think that is what we discussed. How do we diagnose low back pain, right? So we did talked about, right, three different way through history, examination, and our assessment, right? So I think that's what you meant. So low non-specific is basically when there is no cause. Specific is when you do an X-ray and you find something problematic, or an MRI, right? And syndromes we discussed about, right? So syndromes you can again symptoms, right? Numbness, tingling in the legs, all those things. So this is how we diagnose. And category wise, we divide it into three different categories. Any other questions out there?
Any other question, students? Any other question? I think that's all, sir. Thank you very much. At the end, I would like to thank the management, our chairman, director, principal, all the faculty members, staff, IT cell, our students. Thank you very much. Above all, I would like to thank Dr. Amar Sohail for the wonderful session. Thank you, sir. It was very great hearing you.
Thank you, ma'am. Thank you so much.
Thank you, sir.